So Mike gave probably the same talk or so, I imagine, for last year's group, kind of in the second half of the year, or maybe even further towards the end of the year. And it was pretty darn good. So we said, let's get this talk going at the beginning of the year instead, so that we can lay some foundation for you guys as you look at all these cases. I think he'll make a very compelling argument that Amber, the other day you mentioned, like, let's think more deformity versus degenerative. And I know you were talking more about the procedure itself, but I think Mike is going to make a compelling argument that we should just look at the spine and treat it. And so looking forward, Mike, again, thank you for being here and running through this with us again. And anyways, thanks, bro.
All right. Thank you. Let me see if I can. Oh, my God. Oh, no. Do you guys see it as like the PowerPoint display now?
Yes.
All right. Okay.
Yes, sir.
Yeah, I think, Greg, I sort of think that whole question about when does degenerative become deformity is sort of a bit of a nonsensical question. And whenever you're fusing something, you got to fuse it in the right position or you're going to be up the creek. Here are my disclosures. For the fellows, this talk will we only have a half hour. Just quickly describe sagittal plane development and understand sagittal plane balance and economy. And understanding that there's a difference between balanced and malaligned. And to understand some of the proposed alignment schemes and their faults, and then to consider individualized alignments in the setting of statistical imperfection. So, apes have a globally kyphotic spine, right? And we're not too far removed from the apes, but one of the differences is that we have bipedalism. Much like apes, we develop in kyphosis. So the sacrum is in kyphosis, the lumbar spine is in kyphosis, the thoracic spine is in kyphosis, and the cervical spine is in kyphosis. And only when we develop bipedalism and continue skeletal maturity or skeletal growth to maturity do we sort of finalize our secondary sagittal planes. So as we become mobile, the curvatures change. First, you do tummy time and you look up and you get cervical lordosis. Then you start to crawl and you get a bit of lumbar lordosis. And then when you stand upright, that is when you have a sort of normalization and maturation, probably a better word, of lumbar lordosis and cervical lordosis, which are just responses to pelvic incidence, which is generally fixed once you are skeletally mature. Or close to it, and thoracic kyphosis, which for anyone who does pediatrics understands that thoracic kyphosis is actually generally kind of varied and unrelated to pelvic incidence for the most part. The whole goal of acquiring these sagittal contours is to stand in what Dubuisset called the cone of economy. So there's a very small cone within which you can stand without expending much energy. And for me, and I know talking to Greg about it, like when you hit a home run with a PSO, the people will come in and say like, "Oh, doc, I could just stand and look out the window all day." Whereas before they couldn't stand for 5 or 10 minutes. And now they can lock their hips and knees and they just stand upright and they don't do any work because they are in the cone of economy. And for those of you, if you still like believe in age adjusted and things like that, you have to understand that if you lock your knees and hips and you've got a flat spine, you have to retrovert your pelvis, and that requires work. And you are out of the cone of economy, even though your C7 SVA may be some sort of acceptable number. It's because you're working and expending energy to stand like that. So what about when we leave the cone of economy? It's a frequent indication for surgery, right? We still all talk about Glassman's paper and the impact of forward sagittal plane alignment on health-related quality of life. So there's really no debate that forward standing sagittal alignment can be debilitating. However, as we all know, it's not ubiquitous that it is debilitating, as there are a number of people who are forward and have no health-related quality of life complaints at all. And so the first reasonable attempt we had at classifying adult spinal deformity was the Schwab SRS classification, where they talked about the sagittal modifiers. one of the important takeaways of the Schwab classification is that they identified the importance of pelvic incidence in determining your sagittal contours. And now, like fellows, you should all look at this. Like, this is the original SRS, right? Schwab classification. It's not plus or minus 10. It's pelvic incidence minus LL is less than 10 degrees. Minus 10 degrees gives you a 20-degree range, which is totally different. Moderate deformity and marked deformity, right? But these are categories. And this assumes that the pelvic incidence lumbar lordosis relationship is static across pelvic incidence values, which is, as we now know, not correct. They also then classify global alignment using SVA. SVA is a terrible marker of standing sagittal plane alignment. It is only a reasonable marker for you to compare to the patient's last or future sagittal plane sort of global plums. You can't average them over a population, and you can't compare 4 centimeters to one person to 4 centimeters and another person. It doesn't work like that, particularly because your SVA is dependent upon your pelvic incidence. And then they also used pelvic tilt, which again changes with pelvic incidence, and this is an immature way of looking at standing sagittal plane alignment. One of the problems also is that when you categorize continuous variables, you risk misclassification. So if someone's 11 degrees, are they non-pathologic or is that a moderate deformity? If they're 21 degrees, where do they fall? And are they actually different? They're probably actually not different, which is the problem. So if we're going to do surgery, then the goal is normal, isn't it? Stephen Gould was a biostatistician who was diagnosed with cancer and went in and said, well, what does this mean? And they said, well, median survival is 1.8 years. And he said, I don't care what median survival is. What's my survival going to be? And so that's why we need to work towards more individualized targets. Using a 20-degree range for lumbar lordosis based upon your pelvic incidence, that gives you a pretty broad range where perhaps you're going to be normal for you and perhaps you're not going to be normal for you. And then given that pelvic incidence is linked to both lordosis, kyphosis, cervical lordosis, your T1 PA and global sagittal angles, it's really likely that chasing some within 20-degree thing, within 10 degrees, which is actually a 20-degree windmill now, is erroneous and we are misguided. The next useful for me sagittal plane classification system in terms of how I have come to look at it and think about it even now in AIS. It's kind of remarkable in AIS that sometimes you can look at their sagittal planes in the setting of their coronal plane contours and still sort of see a Roussely 1 or a Roussely 2. AIS is rarely, it seems to be high PI for some reason. So Roussely, he knew I was as one of the sort of French pioneers, understood the relationship between pelvic incidence and standing alignment, and what he called was normative sacral slope, right? Which is just another way of looking at how you are standing in terms of how much pelvic tilt you have. And his paper, though, used a cohort of 160 asymptomatic volunteers to originally describe 4 subtypes and then refounded it to 5 subtypes. And this classification was based upon the sacral slope of the patient, and conversely, you could say pelvic tilt of the patient, and the shape of the lordosis, the distribution of the lordosis. One of the very interesting things is, if you read it and sort of think as you read these papers, is that he realized the random choice of L1 in our measurements as the upper end vertebra of lordosis. In some patients, L1 to L3 is kyphotic. So L1 to S1 is not your maximum measure of lordosis, nor will it provide you with useful information. And that's probably how we want to stray a little bit with doing ACRs up at L1, L2 and thinking we were doing a great thing when in fact we were making very difficult problems to fix. But that lordosis distribution changes with PI, and the inflection points between spots of lordosis and kyphosis also change. So what should the upper end and lower end vertebra of your sagittal plane comps be? T11 to S1 or L3 to S1? Really depends on what your pelvic incidence is. So the Roussely classification, very simply, if you think about it, the first way to divide it is into low-grade PI and high-grade PI, where high-grade PI is 55 or higher, and low-grade PI is under 55. And you can see that type 1s are a sweeping kyphosis, where the apex of lordosis is actually the L5 vertebral body, and they have a very small arc of lower lumbar lordosis, lumbar lordosis. Type 2 is where you get into the very classic, like if you were to draw a picture for a patient, the S shape, but it's a sort of small inflection point S shape. Type 3 anteverted, Type 3 and type 4 are just larger S shapes. And these are larger S shapes because the pelvic incidence goes up, which means that the upper arc of lordosis becomes larger. The lower arc, as you will see, is kind of the same across all people. And then the S shape becomes larger because they want to maintain horizontal gaze, and you have to have more thoracic kyphosis. A type 3 anteverted is a low-grade pelvic incidence person that perhaps gets too much lordosis, and then they rock their pelvis forward. And to some degree, these are sustainable and okay, but for the most part, you want to really avoid giving someone too much lordosis and making them antevert. So what is the goal of what we're doing, right? Ultimately, it's going to be the improvement in symptoms and creating a durable result, then finally minimizing fusion levels. And this last thing even came up with a sort of discussion Greg and I were having on Saturday night, but I think that if we focus on all these trivial outcome improvements, we're wasting our time. And the idea of doing an MIS TLIF so that your blood loss is 40 instead of 100 for an open TLIF, and your length of stay is perhaps 1 day shorter, we're chasing down the wrong thing. And any spine fusion is wildly non-biologic and non-anatomic, and 1 year results and far beyond matter so much more than 6 week or 6 day or 6 hour outcomes, where we really need to focus on, in my opinion, what's important. Then once we figure out what's important, how to do it, then go for it, make the incisions as small as possible. So the goal of reconstruction and trying to make things more durable, this is somewhat where the age-adjusted alignment targets came from, though it was initially just proposed as targets for health-related quality of life, which, if you read the papers and think about it and talk to your patients and consider the complexity of health-related quality of life, it's really a lousy outcome measure. And it's extremely hard to predict because they are so multidimensional. But so what they did was they looked at a group of asymptomatic older patients and said, oh, you're asymptomatic, but your health-related quality of life is okay. This must be a tolerable sagittal plane alignment. And maybe if we fix people like this, well, maybe we'll do better. So then they looked at whether or not these forward sagittal plane alignments would decrease proximal junctional kyphosis or proximal junctional failure rates. And when you read these papers, at first thing, does this pass face validity? That's the first thing you have to look at when you guys read papers. Does this pass face validity? Does this make sense? Or if I said this to people, they say this is nonsensical. I would say this is nonsensical. Spine degeneration is multifactorial and certainly attributable to age. Age is not static, right? Tenet, a good movie, shows you that time for us moves forward. And age, right, is not static. We are constantly moving forward in the time pathway, and there's no way. So what do you do when someone's 50? Do you fix them as if they're going to live till they're 65, or do you fix them as if they're 50, and then when they're 65 and they have adjacent segment disease, do you do distraction osteotomies and flatten out their lumbar spine? The other thing, right, is that we're pushing age adjusted in the setting of also pushing the concepts that biological age is far more important than chronological age, which is something that I absolutely agree with. So we need to put our ducks in a row and pick which ones we're going to stick to and which ones we're going to pass on. And then in this paper, then they make recommendations for alignment based upon age only, and it ignores any influence that pelvic incidence has on all of these measures, and pelvic incidence is completely related to all of these measures. So at a minimum, if you're going to offer targets for these sagittal plane alignment segments, you need to account for pelvic incidence. And the other problem, the real problem, right, for this one is that it ignores the biomechanical considerations of fused and forward. Not fused and forward is not the same as fused and forward. The stresses on the construct, the implications for your pseudoarthrosis rate and proximal junctional failure rate are you can't have a pseudoarthrosis if you're not fixed, and you can't have PJK if you're not fixed. You certainly can get multi-level spinal compression fractures, like the old woman with a dowager's hump whose bone is too weak to hold her up, and she has too much anterior column force from her forward sagittal plane, right? That's probably one non-fusion way of seeing the similarities between the detrimental effects of forward sagittal plane for fused people and forward sagittal plane alignment for people with osteoporosis. The real problem is also that the statistics for this paper are not good. And I can't imagine this getting accepted these days, right? Where every time you submit some, now people become so fanciful with propensity this and that. And I don't even think people sometimes know what propensity means. But in this paper, they looked at the relationship between age and sagittal plane alignment only. And they did not consider any confounding variables, which is erroneous, right? That is frankly wrong. And the problem is that degeneration is the primary factor upon which sagittal plane sort of sets itself. And age affects degeneration. So as you age, we know from the Bowden papers and James Kang's cervical stenosis and spinal cord injury paper that as you get older, your rate of arthritis and your rate of spinal canal stenosis, which is a proxy for degeneration, goes up. And so the problem is, in these papers, if you controlled for age and degeneration, what I am confident you would see is that age would drop out. And these are really degeneration adjusted alignment targets. It's called an instrumental variable when you're looking at the relationship between 1 and 2, but there's another variable that directly affects your independent variable. And so in this one, it's a relationship between alignment and degeneration, where age is an independent variable acting directly upon degeneration, and we're missing that connection. So here's the Kelly soapbox that I'm sure Greg's waiting for, but that undercorrection leads to persistent compensatory mechanisms with pelvic retroversion and adjacent segment hyperextension. And the good example of that is L4 to S1 or L5 S1 isthmic spondylolisthesis that's fixed totally flat. You'll see that the superadjacent segment oftentimes hyperextends quite a bit. Persistent compensatory mechanisms lead to an unfavorable biomechanical environment for fusion because it leads to tension in the dorsal column, PJK because you are moving the fusion mass dorsally while the rest of their spine is trying to go ventrally, adjacent segment degeneration, which I just think is a less impressive form of adjacent segment problems than PJK, though I think that their etiology is the same. And it also leads to an unfavorable biomechanical environment for the hips, right? As if you have a native hip and you retrovert your pelvis and then you walk around like that, we have essentially given you acetabular dysplasia and your joint contact forces in the hip joint change. Then you wear out the joint. And then we say oh, wow, look at that. Spine fusion is a risk factor for hip arthritis, even though it may be spinal malalignment is a risk factor for hip arthritis. There's very few papers written about this topic, but this is one that was in Spine Deformity Journal by Woo-Jin Cho, showing that the adjacent segment forces do go up as you retrovert your pelvis to compensate for a flat spine. So there's a little bit of evidence out there to support this idea. True overcorrection also increases strain on the construct because they bend forward to try and put their head in the middle. And this all supports the concept that fusion must put the patient in the cone of economy. So the European Spine Study Group, this is the next important concept, is the GAP score. One of the primary things to take away from the GAP score when you read that paper is that they found that older patients were less tolerant of malalignment. And if you're over 65 years, you get a point right from the get-go because you are intolerant of being malaligned, which flies in the face of the concept of age-adjusted alignment targets. The external validity of this has been challenged time and time again, which is not surprising. It's hard to sort of validate, especially composite outcomes where they didn't use just pseudo and PJK. They used any implant failure. And when you have, put things like iliac screw failure in the setting of a successful lumbosacral fusion, that sort of changes it, and it's hard to always validate things with composite outcome measures. The concepts are the key, though. The concepts of gap were relative pelvic version, where relative was relative to PI. Relative lumbar lordosis is a PI-based lumbar lordosis target. Lordosis distribution index, again, is an idea of the shape of the spine. Some of the problems with gap, though, is that lordosis distribution index, if you have a lordosis of 2 degrees with one above and one below, it's 50-50, and you're going to get an okay lordosis distribution index score, even though your alignment stinks. But it's really the concepts that are key for you to understand. And so now, right, what about age adjusted? So what about this is a person from our study you'll see in a second, who is older, who was degenerated, but totally asymptomatic, ODI of like 8 or something like that. And their gap score is 10. Gap score of 10 is bad. So should we fix this person like this with a flat back and pelvic retroversion, or should we correct them? And that's a big deal. This is a surgery that's done all the time in this country. And to have the experts and thought leaders in the field debating about this constantly is a huge problem. We need to figure it out and agree and treat people properly. So that led me to the multi-ethnic alignment normative study, which was people from 5 countries who are asymptomatic. And then the first thing I did was say, well, I don't care if you're asymptomatic and degenerated. I really just want to know how people stand. So we just excluded everyone with degeneration, any hint of a scoliosis, and somehow one person with an ODI over 20 snuck in. These are the primary angles that we measured. We measured pelvic incidence, the L1 pelvic angle, right, which is a line from the centroid of L1 to the femoral heads, and the angle formed between that line and S1 to the femoral heads. L1 tilt, which is just like pelvic tilt, right, centroid to femoral heads in a vertical line. T1 tilt and T1 pelvic angle. We did it for every single vertebra, though. And very interesting, what you'll see here in this example, right? This is a PI of 80 person. This is a PI of 30 person. Their L1 pelvic angles, very different, right? Because L1 pelvic angle is a function of lordosis and the distribution of the lordosis. But their L1 tilts are identical, right? Because tilt is a measure of balance. How far away from this vertical line through your legs is L1? And what you'll see also is if we did C2, the French talk about the odontoid hip axis, where you want to come pretty close to being able to draw a line straight down the odontoid and run through the legs, because people tend to stand with very similar C2 tilts, irrespective of their pelvic incidence. So first things first, we have a bunch of ages in this thing. Alignment by age with degeneration removed. There is no relationship between standing sagittal plane alignment and age if you remove deformity or degeneration. There's none. And I think this pokes a real hole in the concept of age adjustment. Right, and I already said that T1 tilt and L1 tilt are measures of sagittal balance, and they are independent of pelvic incidence and the global sagittal alignments, T1PA and L1PA, right? There's no relationship here. Pelvic tilt and the pelvic angles are highly correlated, which is not too surprising because they are the T1PA and L1PA are based upon your pelvic incidence and getting your spine into the correct position. So if we want to define alignment by pelvic incidence alone, if you just do lumbar lordosis, it comes out to 60% of PI plus 30. That is a very nice way for you to say, okay, this is our target lordosis is going to be somewhere in this range. But the R squared, right, that which is a measure of model fit, and I think like Greg and Bob know all this, that we do it all the time in the ISSG, and people talk about this predicting this, and these are predictors. It's only a prediction model if you set out a priori to make a prediction model, and then you have to look at the R squared, because if your prediction properties stink, then it's not much of a prediction model. A good example is invasiveness. The R squared of the invasiveness model is 0.2. It's not good. R squared for LL by pelvic incidence is 0.3. Not good. LPA by pelvic incidence is 0.6, which is much better. It's not perfect, but it is much, much better. And you can see here, this is an 80% confidence interval around here, prediction interval, and it's 4 degrees. So L1PA is 50% of PI minus 20. Dan Rue always taught me to work in zeros and fives, so I dropped the 1, minus 20. And then you have a 4-degree range on either side, and you will capture most people. There are very few outliers. And now trying to figure out what the outliers are, my hypothesis is that it's actually the shape of their acetabulum. Because if you can engage more pelvic tilt or less pelvic tilt and not be uncomfortable, it is probably a function of your hip joint. So now if we're defining alignment by pelvic incidence alone, some other things to look at that sort of poke holes in some of the concepts that we say all the time. There's no relationship between lordosis at L5S1 and pelvic incidence. It's a flat line. The average is 25, and it seems to run from around with about a 10-degree interval around it. So 15 to 35. L4 to S1, right? The low lumbar lordosis, where everyone says you should have 2/3. It's unrelated, right? It's closer to 40 degrees, and it is only once here. And where'd my arrow go? You can see here, right, that it doesn't, these different bars are different pelvic incidence models. They don't diverge until we're up at the L3, L4 disc. And what does that tell you? That tells you that Ruseli is really onto something with this concept of distribution and magnitude, right? Because these are where the Ruseli 1s and 2s are separating themselves from the Ruseli's 3s and 4s. So you don't get any small relationships between lumbar lordosis and pelvic incidence until you start getting very high pelvic incidence, because that upper arc is changing in the high people and it is not changing in the low people. And this is just an example. This is put in for Bob and Greg also, that this is a case I did at WashU prior to my departure. This is MIS front back. Those are all like, that's what, how many words is that? 4 verboten words from WashU, where we used to do it all posterior. You do this all posterior with a T-lift. This would be flat. That 3-4 disc would hyperextend, and this poor, she was deaf, 73-year-old lady would come in with adjacent segment in short order, and then you would probably say you're too old for a PSO, and then you would march up her spine with a flat back at the bottom and ruining it. And instead, she got a lordosis of 40 degrees to put her close to the range of average with a nice low L1PA. And you can see how the distribution of her lordosis changed. This hyperextension here went away. These flattened out up top, and the L1PA went down. And how else to conceptualize just for L1PA so that you guys can understand what we're saying. So think about a person with a pelvic incidence of 40, where their normal lumbar lordosis should be 54. So high lumbar lordosis, this I would prefer to say normal lumbar lordosis. And this is only 5 degrees under PI, but 15 degrees off of an appropriate target. So if you give them 35 degrees of lordosis, but it's all distributed high here, so the case to think about is sort of think about the L4 to S1 that someone else is fixed flat, and you do a couple ACRs and you get the lordosis close to PI and you think you did a good thing. The LPA will still be high. The only way for them to get back into the cone of economy is to retrovert maximally and then flatten out their lumbar or their thoracic spine. Extend through their thoracic spine as a compensatory mechanism. What if you get it all low? You get like a 30-degree A-lift in, and then you don't do anything else because you're worried about overcorrecting. The problem is then this is a low lordosis with a low LPA, and they're going to rock back still again and have to decrease their thoracic kyphosis even more. If you get the lordosis